Okay, thank you for the opportunity. So, if you have something like this, a pterygium, I think this is distorting the central cornea. Better to get the pterygium out and then do cataract surgery. If it's a very early pterygium, maybe you can leave it. So this is topography before and after pterygium surgery. You see the amount of flattening that is caused by the pterygium. So your K values can really go wrong. The other thing that we consider is the dry eye that is associated with cataract surgery. I will not go into the details of the lacrimal function unit, but something more important is the perception of pain that we get. There is a thalamic center for pain. And there are 4 processes of any pain. The first is the transduction, then transmission across the spinal cord, then modulation that happens in the brain, and then the perception. So that is very, very important in the perception of the post cataract surgery dysesthesia. It may not really be dry eye. So preoperative planning, we should look at the K values. If the keratometry is showing, if you see some random spot like this, it is likely that the patient has got a dry eye. This patient, after putting an artificial tear, the K values are normal. So what is the impact on dry eye on the preoperative planning? Obviously, the cataract surgery calculations, K values can go wrong. Even your toric axis can be wrong. So if you look at the patient in a diffuse illumination, you may not exactly detect it. Just put a fluorescent drop and see, or see a parallelepiped image, you can see the punctate erosions. So this is something very useful. Is it a video? Can you click on that? Yeah. So tear breakup time, just put a drop of fluorescent and see, nothing else. You don't need any sophisticated diagnostic equipment to diagnose this. But if you see that the tear film is spontaneously breaking up, like in this patient, I don't know whether you can really appreciate. I can see it in the monitor over here. So you know that the lacrimal status is not great. So you have to tackle the dry eye properly before you take the patient for cataract surgery. There are a lot of drugs. A lot of old people use the Parkinsonism drugs, antidepressants, beta blockers are also very commonly used. All these things can either augment or cause dry eye. And even long-term diabetes will cause some amount of neuropathy, which will cause the dry eye. And obviously, connective tissue disorders are associated with dry eye. So all these things will add to dry eye, and you have to be aware of that. So you don't need any dedicated mammography device. Even your autorefractometer or your OCT machine, you can flip your lid and see the Meibomian glands, and that is an indicator of the status of the Meibomian glands. Is dry eye common? That is a very important question. The companies keep saying that every patient you have to give this lubricants before and after cataract surgery. So this is one of the largest meta-analysis in which they have looked at 9 studies and about 775 patients. So what they saw is that around 37.4% developed some amount of dry eye, and mostly the factors that were incriminated were the incision, the long exposure time during surgery, and the prolonged use of betadine. I'll just touch upon the corneal bloods, the nerve supply. Cornea is one of the most densest part of corneal innervation that you can find in the body. It has about 4,000 to 7,000 terminals per square millimeter, highest in the body. So any cut in the corneal nerve will cause lack of corneal sensation. After LASIK, your corneal sensation comes to normal after about 6 months. After keratoplasty, more than a year. And after cataract surgery, at 1 month, you are likely to get the maximum dry eye. That is because the neurite cells emerge, and there is a stark increase in the neural growth factors at about 25 days. And that is the time period where you get the maximum symptoms. So what actually happens during cataract surgery? You have a cut in the cornea. It may be a small cut. It's hardly 2.5 millimeter, but still it causes denervation of the cornea to some extent, and that can impair the wound healing, epithelial permeability, and all that. And so that can lead to some amount of dry eye. So what are the factors that are important? One is the type of procedure. If it is a phaco, it is a small wound that you are causing, that is less likely. If you have a large wound like SSCS or an ECC, you are cutting across a lot of nerves, and so the chance of dry eye is more. The type of ophthalmic solutions that you use inside the eye, intraoperative medications. Betadine also, Gopal was stressing about the need for putting for 3 minutes, but don't put too long. It can be epitheliotoxic. Operating light exposure also, you don't keep it at maximum brightness, which is comfortable to you. The minimum possible brightness is best. Then coexistent disorders should be taken care of. And the timing of the surgery is also important. If you operate for more than half an hour, the chance of dry eye is more. And to some extent, the cumulative dissipated psychoenergy is also important. So the only thing that you have to see is just put a drop of fluorescein and do a tear breakup time. If the tear film is breaking up soon, or if there is a corneal staining, definitely you have to defer cataract surgery. So if it's a mild dry eye, you can go ahead with the cataract surgery. You can't postpone it for a long period of time. So use some artificial tears. It is better to use it preoperatively also. And better to use something such as a hyaluronic acid or a combination of hyaluronic acid or PPG, or even better would be hyaluronic acid plus trehalose. It takes about 1 month for the dry eye symptoms and the signs to improve, actually. That is what the evidence says. And if you are prescribing omega-3 fatty acids, don't give just BD and all that. Give less than 1 gram, it does not work at all. So 1.5 grams should be given. So there are studies, I think industry-driven studies, but they compared 3 groups. One group in which no medications, the dry eye scores were maximum in the group C. That means no postoperative lubricants were given. In the first group, preoperatively they gave lubricants, and postoperatively also lubricants was given. In the group B, actually, it was only given in the postoperative period. So the dry eye scores are the least in whom we use preoperatively also. So in my practice, what I've seen is around 20 to 25% of people get dry eye after cataract surgery. And especially in predisposed people, I definitely give preoperatively some good lubricant. So we were telling about the incisional damage you do at micro-incision cataract surgery. And in a patient who has got a dry eye, better to avoid astigmatic keratotomy. I'll just take 1 minute. Then limit the drop exposure. Your nurses will keep on putting the dilating drops. Don't do that. That can cause epitheliotoxicity. Then even povidone single drop application is better. Preservative-free drops would be better. If you can give preoperative lubricants, especially hyaluronic acid and PPG, it would be better. Then while during surgery, consider coating the ocular surface with a dispersive viscoelastic agent. You do it only 2 or 3 times during cataract surgery, and that should be enough, rather than putting drops, keeping on pouring every time. Reduce the surgical time by reducing the microscope illumination, and don't use excessive illumination, and limit surgical trauma as much as possible. And if you're doing femtosecond cataract surgery, suction ring, if you take multiple suction rings, take it in and out, there can be more damage to the structures, and there can be more dry eye. So in the case of a moderate to severe dry eye, we have to use cyclosporin, omega-3, sometimes even lacrimal plugs. So we have to defer cataract surgery. We give this cyclosporin. The effect will come after only 3 or 4 weeks. You give good lubricants, something containing hyaluronic acid and CMC, or hyaluronic acid plus PEG plus HP-GOR, that is a stain or something similar. And wait for some time, 3 to 4 weeks, and then only consider cataract surgery. Always a good idea to start cyclosporin and omega-3 fatty acids also. If it is a severe dry eye, you have to look for collagen vascular diseases. Look at ESR and CRP at least. And if it is high, have a rheumat consult and get it under control, and then only do cataract surgery. And in certain situations, you have to give systemic steroids also. This is a patient with rheumatoid arthritis. After cataract surgery, he developed a corneal melt. We did a lacrimal plug and just gave systemic steroids, and it got better. In SJS, the situation is different. It causes wipeout of the Meibomian glands and margin keratinization. So it's quite often you see that the Meibomian glands are very low. And in such situations, you have to be very careful. You always can do a punctal cautery, which can be like a plug. It is a permanent plug. This can be followed by a phacoemulsification. In OCP with adherent leucoma also, better to do a phaco. If you have PUK, the disease has to be under control before you attempt any cataract surgery. This is a patient who had a PUK, had the disease under control, had a crescentic lamellar keratoplasty, and had a cataract surgery. So cataract surgery is universal. Dry eye is universal after cataract surgery, and the treatment of dry eye is demanding, and optimization of ocular surface is important to ensure a good surgical outcome. Thank you.
Thank you, sir.